Hi. We're fine. We're now live at Facebook.
Good.
Yeah.
And I think we've got everyone, haven't we?
Yeah. We're just waiting for our team is back. Yeah. So I think we can start.
Yeah.
Hi, everyone. Welcome to our workshop. We just need to fix the date for the final submission of the paper. At mid-January or late January would be a good day for the deadline. Bijoya said that in late December or mid-December is very busy for her in China. She has to do lots of reports. So we thought that January, mid-January will be a good time for the deadline. Would be fine with you?
Yeah,
all?
yeah, that's good.
Okay.
That will be fine.
And then we'll confirm it via email, and I will let Hamish, Hollet, and the other editors know about it. Okay, this morning, very morning, yeah, Canada and Brazil, but quite too late in New Zealand already. At Britain, they are starting the day about 10 a.m., but we are here all together. Yeah, so very much for joining us. Today we have in the afternoon Stephen Peckham sharing the session, and we'll have comments at the final from David Hunter, Gerald Bloom, and then everyone can share their thoughts on the paper as well. And Tenbensel and Pushkar have written this wonderful paper on policy capacity and health system strengthening in New Zealand. So Steve, with you now to start and coach him. Yeah, thank you.
Okay.
So
Right.
I'm going to keep you to time, Tim, so I shall give you a shout as you get near the 20 minutes.
20 minutes, thank you. That's what I was hoping and expecting. So thank you. It's good to see everybody. And for those I don't know, it's good to meet you. I'd like to introduce Pushkar Silwal, who's my co-author and is actually... All right.
Be careful what you're saying.
Yes, I got that far. Yeah, and Pushkar's currently doing a PhD on health system improvement in New Zealand. So he's had enormous skills to offer in this paper as well. But I do want to say that this is quite a provisional paper. It's in its early to middle stages of development. And we're trying to push the policy capacity literature in a couple of directions at once. Whether it can be pushed in those directions, I'm interested in your feedback. So basically the idea is that we want to apply the concept of policy capacity to the area of health system improvement, which I'll talk a little bit about in a moment, but do so at the local level rather than at the national level in New Zealand. And we'd like to also try to examine the relationship or the dynamics between the parts of the policy capacity map, I guess. So not aware whether that's been done before, but we may be wrong about that, whether it hasn't been done before. So we got our focus is a policy that was implemented in 2016 or began in 2016 called the System Level Measures Framework in New Zealand. And we have a few provisional conclusions, but not many yet, but we're on the way. So putting it in context, health systems strengthening and policy capacity was the subject of the call for paper. And we regard health system improvement as a sort of subcategory of health system strengthening, which is quite broad and quite general about health policy. And it's the part of health policy that it talks about or focuses on the improving health outcomes through the measurement and monitoring of indicators. Following the sort of the vast literature of Peter Smith and colleagues. So health system improvement with that sort of idea that of using indicators as central is therefore something that requires policy capacity to identify and collate and interpret data, to plan things and implement them on the basis of that data and that information, and to manage the political dynamics of stakeholders. So the three broad elements of policy capacity, I think, are all very much part and parcel of this area of health system improvement. Now, we also regard this policy, the system level measures framework, as an attempt to actually generate health policy capacity at the local level. I'll talk a bit more about that later. The third component that we're sort of bringing, or element that we're bringing in, is the idea of the dynamics of policy capacity. So going beyond, I think, the idea that it's simply a diagnostic framework, or not simply a diagnostic framework, but it's generally used that way. To talk about process issues, how does policy capacity emerge? How is it developed? How's the development supported or blocked? And is there an order or a sequence to strengthening of policy capacity? So this would require a more dynamic approach to the concept, and this is a very rough sort of indication of what that might look like, that there might be relationships between different subcomponents of policy capacity, that, for example, the organisational political element of capacity might then support the analytical capacity. So I'll go on and talk about an example of that later. But that's the idea that these things can strengthen each other, and you may actually get virtuous circles, or you may get vicious circles where capacity is weakened over time, or there may be sort of negative feedback loops that you can trace between these, where energy goes into one area and is dampened when it comes back. We need to say a little bit about the New Zealand health policy context. Many of you will know much of this. I think but the key organisations are district health boards. There's 20 of them, and there's also intermediate primary care organisations, or called primary health organisations, or PHOs. The context of colonisation is extremely important in New Zealand. It really does underpin a lot of health policy issues and debates. So it really grounds our discussion of health inequities, which is a very strongly based in inequities between our Indigenous and non-Indigenous populations. But also there's a significant component of the population that have Pacific Island origins, and where there are significant inequities as well. Both Maori and Pacifica also developed their own health providers. So that sort of underpins the policy emphasis on inequities that has been around for about 20 years. To give you an idea of what a health system looks like at the local level, this is a very, very basic picture, but our district health boards are public organisations responsible for providing some services and for funding a broad range of services. So the public hospitals are contained within this structure of district health boards, but district health boards also contract with non-government providers as well, and that includes the primary care sector. District alliances are sort of formal alliances between district health boards and non-government organisations at a local level. So we're arguing that it's worthwhile trying to use this concept of policy capacity at the local level. It's a good fit with the policy that we are studying the implementation of. But if we do it, I think we have to adapt a couple of things, or the main thing we need to adapt is, rather than talking about 3 levels, we'll reduce it to 2. So we'll just distinguish between the system and the organisational level. One reason for doing that is that, and not talking about the individual level, is often the organisational and individual level are pretty much the same thing. if you're talking about a small district with a population of 50,000, for example, and you're talking about analytical capacity in this area, we're pretty much talking about 1 or 2 people. So the system here refers to the local health system, or what I think Steve Peckham and Mark Exworthy and others called the local health economy at some time back. Whereas the organisational level refers to the specific activities of people in organisations. So the system is a much broader context, but both have an inter-organisational dimension. Happy to, that may not be straightforward. I'm happy to answer questions on that later. Now, the details of this policy approach, I'll just go through briefly. These district alliances of DHBs and PHOs are required to develop annual plans in which they specify how they're going to improve some particular headline measures, and many of these are population health outcome measures. So there are 6 central ones for the whole country, but each district identifies some their own particular performance or indicators, which are called contributory measures, and then they in their plans they outline activities that they're going to do to improve those contributory measures. And the idea is that these are not things that can be done by single organisations, but they require collaboration. So in a way, this is, if we apply the term policy capacity, it's a bit like doing policy capacity from the inside out. In the abstract, talked about the middle, but I think it makes more sense to talk about it from the inside out. That the framework aims to improve health outcomes for people by supporting DHBs to work in collaboration with health system partners. It provides a foundation for continuous quality improvement and system integration. That's the language of the policy, and it's really the onus is on implementers in middle levels of the DHBs and the primary health organisations. I don't want to sort of overemphasise the status that this policy has within New Zealand at the moment. It's only sort of supported by a very small unit within the ministry, but at the same time, it has had some traction at the local level. So these are the sorts of things that are the core of the indicators that are used. These are the types of indicators. So it includes things like amenable mortality, and the top one is also a very interesting one, avoidable hospitalisation for young children. So, but we could go through those in a bit more detail, but that's just to give you a flavour of what they are. And the process is that at the district level, identify one of these. Here's an example for avoidable hospitalisation for children. At the district level, the managers from DHBs and PHOs, you try to sort of drill down into the data and try to identify, aim to identify how much they're going to improve these indicators, and to identify specific actions by which they will do that. So, and in terms of policy capacity, we could see this as an attempt to generate some positive dynamics between the different elements of organisational policy capacity. So it starts really at the operational level. You've got the DHBs and PHOs are meant to sort of set up a process by which they engage the local stakeholders, have a collaborative approach to identifying what needs to be done, and therefore that involves collating and sharing data across organisations that will support analytical capacity, which will then support decisions about what to do. That's the theory. You could also say that, and this is the inside out bit, that should then generate further dynamics at the system level and insist sort of broader planning at the local level. So we've been researching this. Back in 2018, we looked at the implementation across the whole country, 20 districts, and we got to talk to people in all but one of those districts. And we did about 2 or 3 interviews per district, semi-structured interviews, and we also looked at the documentation. In another paper, we've talked about success and failure and the things that sort of lead to relative success and failure in terms of both the process and the substance of the policy. And from that, for our purposes, in this paper, we wanted to sort of drill deeper into 2 or 3 cases. Now, in the draft that we've provided, we've looked at a clear success case and a clear case of failure, really, where this hasn't sort of really taken root. They're similar districts in some ways. District G is a bit bigger than District E. They both have major towns and significant rural areas, but the difference is in the simplicity of the organisational environment. So we've gone back and coded our interviews with this policy capacity framework in mind. Here's a bit of an overview of how we've coded it, and we've tried to sort of look for in the data, tried to look for statements about where one component influences another component, and that gives us our arrows in the diagram. And if we look at our first district, the success case, it's you know, we're still refining how we show this graphically, but what we can see here is there's a lot of action going on in the middle of the diagram at the organisational level, and you can track these reinforcing loops, these positive dynamics, and it does sort of conform to, I guess, the statements from the Ministry of Health about how they see this process as unfolding. And this is enhanced by good relationships broadly between the DHBs and the PHOs at the system level, at the local level. And so a plus basically means a positive influence. And there's all the statements here are positive influences. There's very, very little negativity, and there were good examples of how this analytical and this process was actually generated. Broad agreement, I won't go through the quotes in detail, between the PHO and the DHB in the district, and without getting into further detail, which we don't really have in 20 minutes, quite happy to talk about it as we go. In contrast, and this one looks a bit messier, this is the failure case, and we've got a number of positives and negatives going on here. And again, we haven't quite worked out how we're going to sort of portray this the best way, but this is our first attempt. And there's a lot going on in the left-hand side of the diagram, but basically there's a lot of energy being dampened. There's a lot of things that are not happening, a lot of mechanisms that are not firing, and we can boil it down to the rather tense relationship between the District Health Board and one of the PHOs, the largest PHO in particular. But there's also competition between the primary health organisations as well, which tends to muddy the waters quite a bit. And here in this slide, there's some contrasting quotes about getting the process off the ground, in which the DHB is saying that we wanted the PHOs to set this up, but they didn't seem interested, and the PHO is complaining that the DHB is running it and not really consulting them. So there's clearly some political capacity problems there. So to sort of come to some highly provisional and initial conclusions, I think it is. We think it really is feasible to apply the concept of policy capacity at the local level with some adaptations. It is possible to use this idea of tracking dynamics to identify some positive feedback loops, particularly at the organisational level. But we're not necessarily seeing the idea that the organisational policy capacity enhancement at the organisational level actually spills over into the system level more generally. I haven't talked much about the idea of district alliances, but maybe that can pick up that in questions. There does seem to be, I think, going back to this slide, what you notice in the failure case is the, no, it's the wrong one. This one is sort of the absence of action around analytical capacity. It's like it's not even on the agenda in the failure case. And I think that in this particular framework, it's really dependent on good stakeholder relations and in order to be able to support organisations sharing data, which they don't in the second case. In terms of method and theory, this is very early days, what we could do with this, where this could go. Still, you know, in the process of convincing ourselves that it's worth doing. But we're on the track now, so we have to keep going with it. So I'll leave it at that. And we're very happy to take your questions.
Okay, thanks very much, Tim and Pushkar. That's interesting. I've got loads of things, but I'm not allowed to say anything. So, so I'm gonna. Okay, yeah. Okay. So I'm going to pass over and just because of where you are on my screen, perhaps ask David for some initial comments first.
Okay. Okay, thanks, Stephen, and thanks, Tim, for a very interesting paper, very clear. And the findings from the empirical work which you're using echo many other studies in policy capacity and health system transformation in other countries, but also in the papers for the special issues. So lots to build on, and a good focus on the local level. I thought the meso focus was complementary to other papers focusing on the more macro level, so that was interesting too. I've got 4 points, mainly for clarification, get your response to. Population health gets several mentions, but it seemed to me that the initiative you're describing, the system level measures framework, seemed to be quite narrowly focused on healthcare services rather than health in the wider sense. At least that's what I took from the list of measures on page 8. Your slide actually opened that up a bit more to the wider population health issues. And I just wondered whether there was something to clarify there around definitions. Secondly, the paper is an exploratory analysis, as you say, based on data collected for another purpose. Your interview sample is quite modest, as you've said. And in a way, you're saying this is an exploratory study pending further work. So I wondered whether there was more you could say about mining the data you've got or supplementing that in some way. I suppose one of the things that the special issue could do would be to cross-reference other papers in the special issue by way of strengthening your findings, because what you're picking up is certainly echoed in many other studies. So the issues are quite relevant. But that's going to be something for the guest editors to think about. The third point was the systems dynamics approach with the focus on feedback loops, negative and positive, virtuous circles, vicious cycles, and so on. I wasn't sure whether that was adding an awful lot to what was already coming through quite clearly from the policy capacity framework. And I find it a little distracting going into that set of issues, in addition to the focus on the policy capacity framework, which I felt in a sense was sufficient to account for all the negative and positive features you were picking up in your 2 case studies. Okay. Again, that may be something we can discuss, but it seemed to me that many of the issues that you were picking up in relation to the successes and failures related to whether those organizations were ready for change, in a sense, whether they had in place the essential elements, components that needed to be implemented in order to make change more likely. So that may be something to explore as well. And then finally, as you've said, the discussion section is very brief, tantalizingly brief. And I just wondered whether you yourself had further thoughts about what you might want to say there. But otherwise, I thought it was very interesting, really good paper, and I think there's the making of a really strong paper there. So thank you.
Thank you, David. Thank you.
Thank you, David. Before I'll get you to respond, or I'll ask Jerry for his comments.
All right. Well, again, thanks for a really interesting paper that I do think contributes to the debates that the whole overall special issue is focusing on. I guess my comments come mainly from two perspectives, from the perspectives of my work. I've been doing work on China and how it manages change, but more generally now on issues of governance and management of health systems in low and middle income countries. And I'm wondering if it might be interesting to put a little more focus on that in your analysis. And so in a way, I put the question is, what is policy capacity in a mixed health system? And what are you finding out about that in these local studies? And yes, you're concluding that capacity, and I think these are points worth making, is not simply a collection of skills, but there's the importance of feedback loop. It can erode, but it can also strengthen. So it's a dynamic look at capacity rather than a snapshot measure of it. But I think one of the key things is you're putting the importance of institutions. And I think that could be highlighted a bit more, the role of rules of engagement, and you mention it, but don't say much about it, about trust, about the incentives for collaboration or for competition, and how does a system balance the benefits and the pressure for competition, but the need for collaboration. So you're bringing up a lot of those issues. And I put this here as a second question. What factors influence the performance, of district alliances, which are essentially the institutions you're looking at?
Yep.
And so I think by looking at them as institutions and trying to find factors that enable them to function well or lead them to function badly, you're getting some important conclusions about New Zealand, but actually you're contributing to debates about mixed health systems in general.
Thanks.
And so I just put at the end a couple of questions you might look at in the conclusions. Whose capacity? Because a lot of the policy capacity literature seems to focus on the public sector. But in a way, you're hinting that the capacity of the non-state sector has been important. And maybe they don't have much capacity for negotiating collaborative relations. And that could be an important conclusion more generally. How can institutions be fostered to balance competition cooperation? Because you sort of you mention of New Zealand's old policy about new forms of management, but it does lead to this question of how do you build institutions that are cooperative? And I guess the other question, which might be part of your conclusion, are special capacities needed to support the development of institutions for cooperation in mixed health systems? So I think that would be a really interesting contribution to this general debate about capacity.
Right.
Thank you.
Thank you very much, both.
Do you want to do any immediate responses, Tim or Pushkar, or shall we open it out to the floor?
I have one that probably needs to be said. We have one, and that is some of those questions, Jerry, about the factors influencing the performance of DHBs we tried to address in a different paper, and about what sort of influences success and failure, and that's under review at the moment.
But could some of it be brought in terms of with a lens of capacity? Because it's hard to know what capacity you're talking about and whose capacity.
Yeah. No, it's a good point. And I really like that sort of the collaborative and the competitive sort of issue, which is absolutely crucial here. So, that was the only thing I wanted to clarify, that we had done that. But thank you. But yes, I think all those are really helpful comments and questions.
Did you want to add anything, Pushkar?
Pushkar, yeah.
No, I'm good. Okay. I'm good. Okay. Thank you.
Right. Open it to comments from anybody else. You can either wave at me in your pictures, or if you open up the participants, there's a raise a hand bit that you can trigger so that I can call you in. Yeah, Jean-Louis.
Yes, bonjour, Tim. Thanks for the very interesting paper. I'm just intriguing by one of your preliminary conclusion that organization do not impact on system capacity or do not relate to system capacity. Is it an empirical observation from your data? And because my intuition is that for a system to have a coherent set of policy capacity, the system level need to be responsive to the organizational level, to make it simple.
I share that intuition, and I think that is something that I think, you know, you do. I mean, I think there are other case studies and other examples of that are in the literature. So in some sense, our finding here may be specific to this particular context, and raise questions about that, because I think, you know, certainly the people really sponsoring this program in the Ministry of Health, they clearly want this to happen and see this as the way that district alliances, where they are not really functioning as they should, they see this as the catalyst for them doing so. Now, we know from looking across all the districts that is not happening. You know, there is some strengthening of the alliance that happens through system level measures a bit, but the direction is more the other way. Where they are successful, where they are not successful, it's not the thing that makes the difference. And I think we're pretty clear about that.
Okay, thank you.
Fabiana.
Hi, Tim. Are you saying somehow that the policy capacity concepts from the framework, maybe they are too macro? And when you say that you need more sensitive policy capacity concepts, are you calling the attention of needing? No.
I actually really like the three.
Okay.
Yeah, the operational, analytic, and political, those sorts of ways. I mean, I'm sure you could carve it up further, but I just think that's a nice heuristic that actually stimulates a, you know, sort of some really good questions about what's going on. So I've found it, we've, you know, I and other people I think have as well, sort of found that aspect of it helpful, and I think that is applicable at any scale.
Okay. Any other comments or questions? Or we are kind of on time. I'm going to take a prerogative just to follow on really from what Jerry was saying. I was quite interested about how this works in relation to kind of multi-level governance in one way. And I mean, obviously, formal degrees, institutional structures kind of play into this. I think Jerry's right from that point of view. But and the other thing is kind of how crowded is that policy space. I'm just thinking more about how many organisations, not just thinking, I think as Jerry suggested, about the formal health bits, but who else is in that space and who else might have an impact. And that kind of takes us back to kind of how much decision space. I mean, it's very relevant to what's going on in parts of England as well, so-called integrated care systems and things. So those were just two comments that occurred to me that would impact on that nature of policy capacity as well.
Yeah, I think that's an interesting one, and the contrast to the UK and Canada, I think, with New Zealand in this regard and many other countries, is important as well, because there are potentially other organisations in that space, and there's lots of talk at local levels about engaging with social services or engaging with employment services or you know, sort of all the usual sort of intersectoral conversations. But I think in New Zealand we have a particular issue and problem with the design of the health sector, which is quite all-encompassing or quite widely encompassing in itself. It includes a lot of things that would be in social care or social sectors in other countries, and therefore health has a much bigger problem talking to other sectors at the local level and at the national level. So it wants to get round to it. Sort of, but often it's actually much more in trying to get its own house in order first. It's sort of like it appears that the health organisations never get time to do this properly with non-health organisations.
Okay, thank you. One last call for any other comments. No, if not, thanks very much to Tim and Pushkar. Very interesting. Thank you, David and Jerry, for your initial comments. And if anybody has any other thoughts, I'm sure Tim and Pushkar will be very happy to receive those by email. But a good paper to open the session and kind of focus us down on what we're looking at. So we now have what I think Fabiana's described as a long break. It's probably not a break for anybody, but we're back here at 10 o'clock, 2 o'clock, or 9 o'clock in Canada, would be my guess. So
10 a.m.
Yes.
Will you excuse Pushkar and I from participating in the rest of the day?
I think you could probably. I was just about to come to New Zealand. We might let you off.
Yeah. Okay. Thank you. But I look forward to looking at the videos, and I have looked at the last ones, and it's been a fantastic initiative, Fabiana. So thank you.
Brilliant. Yes, thanks, Fabiana, for organising. And see you later.
Thank you.
Yes,
Bye.
later.
Thank you so much.
Bye.
Thank you.
Thank you all.
Bye.